Hello everyone. Today we'll be discussing about radiation oncology. Well, this one is just an overview. Okay. So, what is radiation oncology? To be really frank, it is basically therapeutic application of ionizing radiation. And if you go by the definition, first of all, it's a discipline of human medicine. It is concerned with generation, conservation, dissemination of knowledge which is regarding the cause, prevention, and treatment of cancers. And the special expertise that we hold is therapeutic application of ionizing radiation. So, radiation oncology is basically a science which borders between two basic sciences, physics and biology. So, what is radiation therapy then? So, radiation therapy is basically the treatment of the patients with ionizing radiation. So, radiation therapy is more related to the treatment delivery. Now, whenever a radiation oncologist plans to treat a patient with radiation, there are six fundamental questions that we all answer. First is, what is the indication? Why am I giving radiation? Second is goal. What do I plan to achieve? Third is the volume, which is the area or the volume that I am going to treat. Fourth is the technique. How am I going to treat this area? Fifth is the dose and fractionation. What amount of radiation am I going to give? And the amount of radiation that is given is actually broken down into pieces, which are known as fractions. So, in how many fractions am I going to give that dose? And sixth, well, all doctors follow this. First, do no harm. So we'll look at the normal tissue and what is the possible tolerance. So coming to the indication. What is an indication? It's basically the body of data which shows that radiation therapy would be efficacious for the patient's condition. For example, early carcinoma cervix, I know stage 2 carcinoma cervix, chemoradiation will help. So the gold standard of data is a prospective randomized phase 3 trial. But they are not always available, specifically for rarer conditions. So, a retrospective single institution review can also support you. And then, something which is very important is your clinical experience and the knowledge of the patient's problems, the logistics, age, comorbidities. There are many factors at play. After indication, we decide upon the goal. We can have either a curative goal or a palliative goal. Curative means that we are taking a risk of side effects, but we are sure that the tumor may not come back in near future. So that is a curative goal. While in palliation, we know that the patient may not be cured, but we have to ameliorate some specific symptom like for pain relief or to stop bleeding or to relieve obstruction. So goal is extremely important because this is one of the factors at play which decides my indication, which also decides my dose, my fractionation, the curative purpose that when we decide that we are giving curative radiation is usually based on phase 3 randomized data. But palliative indications can also be based on the clinical experience of the doctor or knowledge of what the patient needs or wants at this point of time. After goal, we decide the volume. This is actually the most interesting part in radiation oncology. When you sit down and decide what all area are you going to treat and to what dose are you going to treat it, how you are going to treat it. So this volume, technique and dose fractionation, this is like the most interesting part that you will come across in radiation oncology. So if you look at this diagram, you can see that this green area basically represents the tumor, gross tumor that I can see with naked eye, that I can palpate, that can be caught on radiology. So this is usually comprising of 10 to the power 10 cells or more. So we draw a region which is labeled as A here, represented by the red line, which encompasses all this gross tumor. So this area or this target volume is known as gross tumor volume, the GTV. So after this, we know this is the area that we can see, but a region beyond this tumor is having tumor cells, but less than 10 to the power 10, around 10 to the power 8 or even less. So this area you can visualize the tumor cells, but not by naked eye. You can just visualize them only microscopically. So this area of microscopic disease spread is then delineated, and here it's labeled as B, the orange line, and is known as the clinical target volume or CTV. Then beyond this, we take into consideration certain uncertainties, like the patient might move on the couch, or when we had simulated the patient, then the patient position may have varied from then to when the patient is on the couch. So all these uncertainties, the patient's normal bodily movements, when we all take that into account, we give a further margin to this CTV, and we make another area or target volume, which is known as the planning target volume, here seen in purple, labeled as C. And beyond this, we open our treatment portal, which is labeled as D, the blue line. So basically, to treat a gross tumor of this green colored size, I'll actually be opening a radiation portal as big as the blue thick line. So how to decide upon this volume, how to actually recreate it on the system, this is the most interesting thing that we'll be doing in all of our radiation oncology. And next comes out the technique. We have decided upon what volume I want to treat, but how would I treat it? So I have two major modalities at my behest. One is teletherapy, that is external beam radiation therapy, where the source of radiation is outside the body. This is a linear accelerator. We can also use a cobalt 60 teletherapy machine. We can treat the patient with neutrons. We can treat the patient with protons. The other technique that I have, on the other hand, is brachytherapy, where I'm putting the source into the tumor. Here you can see the needles that have been put into the bed, and we have to decide upon what source I'll be using, what would be the dose rate. Teletherapy in itself, we can plan with 2D imaging. This was the conventional radiotherapy, which was used when there was no imaging available. We just had surface markings. We would mark the portal and just open up the treatment portal directly on the machine. But later, with the advent of CT scans and port films, we were able to visualize that where our tumor might lie. So came the era of 3D conformal radiotherapy, 3D CRT. Then later on, with the help of treatment planning systems, we were further able to modulate how the radiation was to be given. We were able to decide at what volume would receive what amount of dose. So came the era of intensity modulated radiation therapy. And intensity modulated radiation therapy is the one which is mostly used nowadays. Then, along with this came image guidance, where we would be able to take imaging of the patient during treatment or before treatment and decide whether it matches our simulation image or not. Then, further precision was achieved when we started treated patients with stereotactic stereotactic radiosurgery, stereotactic radiotherapy, stereotactic body radiotherapy. These are basically very precise mechanisms where very high dose of radiation is deposited in a very small area. Then for brachytherapy, we have multiple types of brachytherapy where we can put the intracavitary, where we can put the source in a cavity near the disease, like carcinoma cervix. We put the source in the uterocervical cavity. Interstitial, like this, where we use needles and put it in the tumors or in the post-op bed. Then a surface mold, where the tumor is very superficial. We take these needles and we put them in a wax mold, and then we put that wax mold over the tumor. So for skin tumors and all, surface mold can also be used. Then intraluminal, where we put a catheter into a lumen like the esophagus or the trachea, and we put the source into that lumen. Now, for brachytherapy, we need to know two terminologies. One is afterloading, and the second is hot implants. Hot implants mean the radiation worker would be handling the radioactive material directly and put it into the patient's body. This was done when like radium tubes were used for treatment, because there was no system of loading it after later. You had to put it there and then. Later, the after loading system developed, which is now the contemporary system, where we have a machine which holds the source. We put in such catheters and tubes, and later we attach these tubes to that machine. That machine loads the source via these tubes, and we can decide dwell points where all we want the source to stay for how long, and thus decide the total dose distribution. So this is the technique, and we have to pick one, how we are going to treat the patient. Then comes the dose and fractionation. Now, dose depends upon what technique am I using. Fractionation also depends on that. For example, if I'm treating the patient with external beam radiotherapy, that is teletherapy, then I have to decide the total dose that I am supposed to give the patient in how many fractions, at what dose per fraction, once, twice, or thrice a day. Once is the usual that we use. Then we have whether I'm to treat the patient 5 or 6 times a week, and the how many number of weeks would the treatment last. For example, for a patient of post-op head and neck, buccal mucosa and all, oral cavity, I might decide upon treating the patient for 60 gray, 30 fraction at the rate 2 gray per fraction, treated once a day for like 5 days a week over 6 weeks. On the other hand, for brachytherapy, if I'm treating the patient, then I have to decide upon whether I'll be treating the patient with high dose rate or low dose rate, with what isotope, what dose per fraction, the number of sessions that I might be giving the patient. For example, in a carcinoma cervix patient, when we give brachytherapy after external beam, we treat the patient with iridium 192, 7 gray each for like 4 sessions. Then we come upon the tolerance. So after we have like decided upon the dose, fractionation and everything, we look at the organs at risk. For example, in that head and neck patient where I want to treat the patient up to 60 gray, but we have the spinal cord there which will tolerate only up to 44 gray. So it also depends upon what technique you use. How would you spare your spinal cord? So the organ at risks and the normal tissue tolerance is very important when deciding upon a patient of radiation. Now, for an EBRT patient, when we decide upon the volumes, there are certain definitions that we basically need to know. One was the gross tumor volume. If you remember, I had told the 10 to the power 10 cells. That's the demonstrable tumor. Imaging, physical examination, visible by naked eye. Then we have the clinical target volume. That is the GTV plus the suspected tumor, the subclinical disease, the microscopic spread. Then we have the planning target volume or the PTV. This is CTV plus margin for geometric uncertainties. These uncertainties can be variation in the setup or anatomical motion. This report also gave us two more definitions. One was the irradiated volume, which is tissue that receives a significant amount of dose, like the entry area, the exit area, the penumbra region. Then we also have the planning organ at risk volume. This is basically a margin which is given to organ at risks, so that when planning the patient, during that we are able to save the OARs more. Now, if you remember this diagram, we had talked about the gross tumor volume, the clinical target volume, the planning target volume, and the treatment portal, right? So if you see this 3D plan, then you will be able to see that this is the gross tumor, while this is the area of subclinical spread, that is the CTV, clinical target volume. Then we gave a margin for uncertainties, making the PTV, the planning target volume. And to treat this planning target volume, this is the treatment portal that we have opened up, the treatment portal of the beams. This is how the beams are coming. There are 4 beams, anterior, posterior, and bilateral. So this is our treatment portal, while the entry beam, the exit beam, all this area which is being irradiated is the irradiated volume. Similarly, you can see it in this picture as well, the gross tumor, the clinical target volume, the planning target volume, the whole of the treatment portal, and the irradiated region. Now, coming to the uncertainties, we talked about these uncertainties that due to which we were giving this planning target volume everywhere, we were making a PTV everywhere. So these can be machine related or patient related. Another classification we have is type A and type B. Type A is which can be evaluated by statistical methods, while type B we cannot decide by statistical methods. Another terminology that radiation oncologists are very fond of using is random and systematic errors. Random errors are those that we have no control over, while systematic errors are those that we can actually measure, like couch sag or sag in the gantry or any incongruence. So we'll follow these two general categories, the machine related and the patient related. Mechanical uncertainties can be due to, well, the field size settings. There might be some difference in the mechanical dials or the digital settings. The rotational settings, the dials for rotation of the gantry might be in error. Crosshairs. We have a crosshairs in the linear accelerator which show the central axis, but then it may become displaced. It might not be the same as the actual central axis. There might be deviations in the isocenter because of sagging of the gantry head. There might be light beam incongruence, which means that the light beam, which actually is we cannot see the radiation portal by naked eye, but we can see light. So we have a light beam which shows us what the radiation portal might be looking like, but there might be incongruence between the two. Alignment system incongruence, that the laser beam systems might be out of alignment. They may not intersect at the exact isocenter. They might be very thick lines. So there might be error in judgment where exactly the isocenter lies, because the isocenter is a point. It is a point where all the axes of rotation are meeting, of the gantry, of the couch, of the collimator. So we'll read up these things in detail. Then there might be a difference in the sag of the couches. The couch might sag over time. There might be difference in the couch sag of the simulator and the machine. There might be error in making of the beam shaping blocks or the collimator alignments or the alignment of the multi-leaf collimators. There can be patient related uncertainties like in the target delineation. No matter how much we image or examine the patient, there might be some uncertainty somewhere in our delineation. There might be organ motion, like in lung. Every time the patient respires, the tumor will move. There might be shift in the skin marks. Like for treatment of the patient, we have tattooed the markings on the skin that this is the position that will match, and then we'll treat the patient. But the patient might be on steroids, the patient might gain weight during treatment, the patient might lose weight during treatment. So these skin marks may vary. Repositioning problems can be there. Every day you're lying the patient down on the same couch for like almost 1.5 months. So there might be day to day changes. And then there is patient motion. Some patients just do not stay still. They might be anxious, they might be in pain, they might have some neurological condition that cannot be helped. So, to bring all this motion to a minimum and all these uncertainties to a minimum, we use immobilization. Now, there are a lot of variety of immobilization that is available. An ideal immobilization device would be comfortable and secure, non-claustrophobic. The first and foremost thing is the patient should be comfortable. If the patient is comfortable, the patient will easily reproduce that position every day for no matter how long the treatment goes. Then it must satisfy the radiation treatment plan. You might be easily able to access the area that you want to irradiate. The volume that you want to irradiate should be easily accessible. It should be quick and easy to set up. It shouldn't be like that the radiation therapist is taking like a half an hour to actually set the patient up. It is tiring and it makes uh, room for more errors. Then the body part treated should be rendered immobile. The less the motion, the less the uncertainty. It should be reproducible for daily treatment. Its construction should be quick and easy. It should not be difficult to train new people. It should not adversely affect build up or backscatter characteristics. It should not alter the beam in any way. If the beam will alter, you'll never be able to understand how the radiation is being deposited. It should be economical, easily available, and if any anesthesia is being used, airway access should be easy. That is very important. Airway, IV access, and use of monitoring equipment should not be difficult. So this is like a ideal system, and there is no immobilization device that fits all these criteria. It is more of a situational thing. In certain situations, certain immobilization devices do better. Some of the common immobilization devices that we use is like the headrest. Basic headrests come in a number of sizes. The It basically makes it easy for the patient to lie down. Then we have the bite block. We basically place a headrest here, ask the patient to rest their head, and ask them to bite this so that the motion of the head becomes minimal. We can adjust its height and its angle. Then we have the intraoral prosthesis. This basically pushes the tongue away from the hard palate. So basically any tumor of the hard palate or even soft palate basically moves away from the tongue, or any treatment volume of the tongue goes away from the hard palate. Very easy to use, very easy to make. It can be made in the department itself and as per the bite of the patient. Then we have the thermoplastic cast, everybody's favorite. This is basically a cast which is fixed to the board on the couch so that the part of the patient does not move. Then we have the vac-lock. This is basically a vacuum bag. It has beams in it. You lie the patient down in it, position the patient, and then you vacuum all the air out so that this becomes tough and does not change its position. Easy to use, easy to put the patient on the couch. Now this thing here is a breastboard with a thermoplastic cast for the patient being treated for breast carcinoma. So you can see that there is a knee rest, there is a breastboard, there are the wings and the support for the hands and the arms, and obviously this can be used with a thermoplastic cast. Then we have the abdominal compression plate so that the movement of abdomen becomes minimum. These are basically used for controlling respiratory motion during your SBRT. Now this is a plate compression, while this is a belt. Does the same work. This works with a manometer. You can decide how much pressure do you want. Then some other immobilization devices that we have here, and the amount of patient motion that they allow. Alpha cradle. Alpha cradle is nothing but something like a vac lock, but instead of beams, it has this foam. This foaming material that you fill into this polythene like structure, and then you make the patient mold out of it. This allows for a patient motion of about 5 mm. Then we have bean bags, like the regular bean bags, the bean chairs that we have. The only difference between this and a vac lock is that if you vacuum it all out, then it becomes a vac lock. It gets locked in that position. While here, the patient motion would be more, so like about 6 mm. Then we have the head aquaplast. As you had seen, aquaplast is nothing but a thermoplastic cast that we had just seen. Then we have this headrest, very loose but comfy, giving us a motion of about 7 mm. Then we have the modified Gill Thomas Kosman frame, giving us a motion of about 1.8 mm. This frame was specifically devised for stereotactic radiosurgery in a gamma knife setup. So this is what the frame looks like, and this frame gets fitted into the machine. So there is almost minimum movement and very good accuracy, very good precision. Then we have the craniospinal head support system. The whole spine and the head is supported in this prone system. We have knee rests, we have foot rests, we have the spinal rests, we have the head rest. Then we have head thermoplastic cast with a bite block. So this is giving us, see, you can see that this is giving us a patient motion of as less as 2.9 mm. That's like 3 mm. So this is what is actually routinely used, the thermoplastic cast. Here also you can see that the thermoplastic cast is giving up to a motion of 3.6 mm. So this is like acceptable on a routine basis. Then we have the wing board, which is for support of the hands. So these were some common immobilization devices that we use for EBRT, external beam radiotherapy. Now, the techniques that we had talked about during external beam radiotherapy, one was 3D CRT, where we were able to visualize the tumor, this region that we have to treat, but our conformity was not that good. So see, you can see that the parotid here, this pink is parotid, this blue is parotid. So they are being irradiated to some extent, while they are being spared a lot more if you plan the same patient with intensity modulation. So this is basically the difference of technique. So in some like a palliative patient, you might not want to spare your parotid so much because your dose might not be that much, or you do not expect that the patient would develop any adverse effects so soon. While in an IMRT patient here, where you might be considering the patient for a cure, there you might want to spare your parotids because the patient will and definitely will come back with some adverse effects. Similarly, for brachytherapy, where I have implanted the source into the uterine cavity, and this is the how the radiation is spread out all around the radiation source. So these are various techniques. I have given you an overview of it. We'll talk about them in detail later on. Now, how do you manage a patient with cancer? You have three very simple modalities for management. One is your surgery, second is radiation therapy, third is chemo. Now, we actually prefer to combine these therapeutic modalities. Like, for example, irradiation and surgery. Now, radiation can be given before surgery, that is pre-operative radiation. So the rationale behind is that we eradicate this microscopic disease, which is beyond the margin of the surgical resection. We can diminish the tumor implantation because when you irradiate, the number of viable cells decrease. So during surgery, the implantation into the operative field would be less. We can sterilize outside the operative field, and the potential dissemination of cells into distant metastasis also decreases. It also increases the resectability. But the issues that we face with preoperative radiation are it interferes with normal healing. After radiation does not only kill your tumor cells, it also hurts the normal tissue like the fibroblasts, and also the healing decreases. It becomes very slow. There might be delay in surgery. The surgery might be the curative treatment for the patient, but because we have started off the patient on pre-operative radiation and that's like gonna go on for like a month or so, there is delay in surgery, and then there might be disruption of the staging. The staging will change. We would not know the initial surgical staging, and the expression of immunohistochemical prognostic factors may also change. The other option that we have is post-operative irradiation, that is, irradiate after surgery. So there is still possibility of eliminating subclinical foci in the tumor bed. That is not an issue. We can still sterilize the nodes. We can actually get an idea when the surgeon is operating, he gets an idea where the margins may be less, how the tumor was spreading. So we can deliver higher doses to these high risk areas where we expect a lesser margin. But the disadvantages are that irradiation cannot be started until the healing is complete. So we have to wait. There is a delay. Then there might be impaired vascular changes. During surgery, the tumor bed might have a decreased vascularity. So radiation effect would be less. Then the other combination of therapeutic modality that we have is irradiation and chemotherapy. Now, chemotherapy, as with surgery, can be given either before irradiation, that would be neoadjuvant or induction chemotherapy. It can be given with radiation, which is concurrent or concomitant chemotherapy, or it can be given after radiation, which is basically adjuvant radiotherapy. Neoadjuvant or induction is terminology used when we are giving a modality before a radical modality, which can be radiation or surgery. Concurrent or concomitant means with, together with. So with the radiation, it is concurrent chemotherapy. While adjuvant is a terminology that we use, that treatment is the therapeutic modality being used is after a the curative modality. For example, after curative radiation, we can give adjuvant chemotherapy, or after surgery, we can give adjuvant chemotherapy, or even adjuvant radiotherapy. So, this is how the terminology goes. Now, what could be the possible rationale or the cellular mechanisms for interaction between this chemotherapy and radiation? One is the modification of slope of dose response curves. We will talk about dose response curves in detail, so I would not be discussing this right now. Also, we'll be discussing about sublethal damage and potentially lethal damage. If these damages get repaired, the tumor cell does not die. So, chemotherapy and irradiation together inhibit this repair. They both have a synergistic effect. Then there is a change in the cellular kinetics. For example, we have hydroxyurea. When we give hydroxyurea, it kills the cells in the S phase. So now you can see in a tumor, some cells are in G1, some are in S, some are in mitotic phase. Everybody is at different places. Now with hydroxyurea, all the S phase get killed. So only you have G1, mitotic, G2M left. And the M phase, G2M is basically very irradiation sensitive. So when the irradiation is given, that is in the cells in the sensitive phase are left, so the cytotoxic effect of the combination is higher. Then there is selective cytotoxicity and radiosensitization of hypoxic cell, which has been demonstrated with mitomycin C and cisplatin. Hypoxia doesn't work well with radiation. If there is hypoxia, irradiation effect would be less, but with mitomycin C and cisplatin we can actually overcome that. Then there is inhibition of cellular repopulation. There is a decrease in the tumor bulk because of chemotherapy. Now, if there is a decrease in tumor bulk, there is an improved blood supply, there is reoxygenation, and that again increases the radiosensitivity and chemosensitivity. So, you see, there's a synergistic effect. So, eventually, what we are aiming towards is an integrated multimodality cancer management. We want to preserve the organ, we don't want to butcher everything or take everything out. So we try to combine as many modalities as possible, and we want to do that because they have a spatial cooperation. Chemo works systematically, it works on the whole of the body, while radiation and surgery works locally. The interesting part about radiation is we'll study on later is the abscopal effect, the immunity effect that radiation has, that to some extent radiation might also have a systemic effect. Then there is synergy, there is addition of the anti-tumor effects, there is no overlapping toxicity. The toxicity of radiation is more localized, the adverse effects of surgery are more localized, while the adverse effects of chemotherapy are more systemic. Then there is protection of the normal tissues. So if you look at it, how do we decide upon whether the patient has been cured or not? We all know that 10 to the power 10 is like the gross tumor, and 10 to the power 8 is the limit of clinical detection, microscopic, right? So, we want to bring the tumor size down, 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 down to be below our limit of clinical detection. We consider it as complete response. Beyond this, once we come into the microscopic, we treat the patient further with adjuvant treatment so that we can bring this down to such a level that we achieve a tumor cure, that in near future the tumor would not be back. Once we come below the limit of clinical detection, it is more statistical now. What would be the possible chances that any tumor cell is surviving? We just want to bring that probability to zero. So, how do we decide upon what modality to give first, what to give second, whether neoadjuvant, whether adjuvant, concurrent, how? For that, we have clinical trials. Basically, there are four types: one, two, three, four. The first trial is for the toxicity of that modality, the second is for what dose and what efficacy, the third is for basically a comparison. The third is a comparison with a established standard modality. That is the reason why prospective randomized phase 3 trials are the gold standard. while 4 is the post-marketing surveillance, that once you have actually started giving out that modality to the general population or to the general patient population, then how are we faring? So it kind of brings us back to our how do we decide what to give when? Now, there is one thing that I actually wanted to talk about right now. Whenever we decide upon giving irradiation, there is one risk that we are exposing the patient to. That is a second primary malignant tumor. Radiation is a double-edged blade. You treat the patient, but you also predispose the patient to a secondary malignancy. So we have the modified Kahan criteria to decide whether this is a second primary malignancy which is radiation induced. First, it will arise in the irradiated field. Second, there will be like a long latent period, around 4 years or so. Fourth, the third, the tumors would have a different histology. And fourth, that tissue where the disease has come up now was metabolically and genetically normal before radiation. The patient did not have any other predisposition to any malignancy. It all happened after irradiation. So this is one risk that all our patients face, and we should make them understand that such a thing is possible, though the probability is very low, but it is there. So now we know that radiation predisposes to development of malignancy, due to which these two things come into place: safety and quality. Safety for both patient and the radiation worker, and quality definitely for the patient, because we cannot separate the two things. They both go hand in hand. And there is a very interesting article, you might say, which was published, Safety is No Accident, sponsored by ASTRO, which is the American Society of Radiation Oncologists. So they published this article, and it is a very interesting read. Now, safety is basically prevention of errors. Any errors that lead to a big therapeutic implication, like treating the wrong patient, treating with the wrong plan, gross mistakes basically. Quality is a subjective issue. It is basically that the volumes, dose, beams, all are appropriate and above a expected standard, right? So Astro in 2011, they actually bought out this article, Safety is No Accident. Um, they talked about the process of care in radiation oncology. Now, how do we treat our patients? First of all, we see them in the OPD. They'll come, we'll evaluate, we'll talk to them regarding the treatment. We'll tell them how it's supposed to be done, what would be done, what would be adverse effects, go through the whole counseling and everything. Then we have the simulation. Simulation is basically a practice of how we'll be treating the patients on the machine. And we take a simulation CT scan or a simulation imaging. Usually it's a CT scan on which we do the treatment planning. We take the CT of the patient, we delineate all those volumes that we talked about, the gross tumor volume, the planning target, the clinical target volume, the planning target volume. And this is how a simulation is done. In the position with all the immobilization devices, we take that CT scan. Then the treatment planning is done. On that CT scan here, we have delineated all the CTVs, the gross tumor volume, the CTV, and we have planned the patient. This is the dose wash that you can see how the dose is distributed. This is the 50% dose wash. So after that, we do a pre-treatment quality assessment and a plan verification. This is basically after the plan has been approved, we check that if the machine would be able to deliver the exact same plan or not. We basically check it before we are able to take up the patient for it. So after this QA and verification has been done, we can take up the patient for treatment delivery. So you see that the position of the patient is similar as the position was when we had taken up the patient for simulation. But now we will be treating the patient on the LINAC. So then comes the one of the most important parts, that is the radiation treatment management and the follow-up care. This is extremely important. The most interesting part was here, where we were doing the simulation, we were doing the planning, deciding the volumes, dose, and everything. But this is the most important part if you want a good outcome out of your treatment plan. Because the patient will start developing adverse effects now. Like this patient has developed dermatitis. This is at 60 gray. This is when the patient reached 70 gray. You can see. This is 10 days after treatment, and this is like almost 1 month after treatment. So you can see how the patient transitioned, and if appropriate care is taken, they heal well. You don't want to uh, treat the patient as such that you cure the patient of the disease, but they end up with very bad adverse effects. So follow up is extremely important. Now, who all people do this? So obviously there are the radiation oncologists, then there are the physicists and dosimetrists. Physicists are basically responsible for developing the plan. You decide the volumes, dose, and everything, but the actual physics of it is done by the physicists. Then we have the oncology nurses who help you with the follow-up and with patient treatment. We have radiation therapists. These are the people who actually sit there on the console of the machine and do the treatment delivery. Then we have other allied forces with us of nurse practitioners and physician assistant, dentists, extremely important, psychologists, psychiatrists, nutritionists, again very important, physical therapists, speech therapists, integrative medicine specialists, etc., etc., etc. So, legal principles I wanted to discuss because malpractice is a major concern, especially with a diagnosis as heavy as cancer. People do not take it very easily. It's a very life changing news that you or your loved one has been diagnosed with a disease as deadly. Despite the fact that in some diseases we offer very good cure rates, things might go wrong here or there. We're humans after all. So, malpractice is a major concern. And the complaints usually fall in some broad categories like the failure of physician to fulfill patient's expectations, like while their examination or treatment, that consent was not taken, or physical examination was not adequate, or there were complications of radiation therapy that they were not told about, or withholding radiation when it should be given, or giving radiation when it should not be given. So, one is this. Then there is failure to make prompt diagnosis, taking too much time, lingering on with investigations and investigations. You have to talk to the patient's attendants, you have to talk to the patient. Then, rude behavior, unacceptable practice behavior like excessive pain or doing something that you should not be doing, related to billings, any drug abuse on the physician's side, sexual misconduct, errors in prescription, and insurance fraud. So these are like the major um, complaints that might come across. And whenever the decision is being made on the malpractice case, first thing to decide is the duty, what the physician was supposed to do at this point of time. So this is usually done by a committee of experts, which also consists of oncologists. So then is if any breach was done, whether the duty was done or not. What was supposed to be done was done or not. Then what was the causation, what happened, and what were the damages? What exactly is supposed to be done after this? So, how do you manage this risk? You will always run this risk. How will you manage it? The best prevention, good rapport. Have a good rapport with your patient and their relatives. See, the diagnosis of cancer is just not for the patient, it is actually for the family. It does not only changes things for the patient, it changes things for the whole family in itself. Everybody is affected. So you need to have good rapport with them. You need to understand how a basic idea regarding their family dynamics. You need to have effective communication. Your QA program should be effective. You cannot slip up there. That is like your job. You should know how things are working in your department and how effectively they are working. Then there There is repo, there is communication, there is effective QA program, but there is no clear documentation. Doesn't work that way. All that you talk about, you have to write. So there has to be accurate documentation of procedures, discussions, events before, during, and after treatment. So the best prevention against a lawsuit is communication and documentation of the communication. So that kind of brings us down on the overview, and I would really like to hear your comments on it. And please share it with your friends if you like it, and give me an idea of what more you would like. Thank you so much for being patient.